We described the PK/PD properties of antibiotics used for C. diff infection and identified risk factors for the development of new onset and recurrent C. diff infections. We also assessed clinical presentation and diagnostic laboratory findings to determine if a patient has C. diff infection. Now, given a patient with new onset or recurrent C. diff infection, recommend IDSA guideline-concordant treatment. Here are the IDSA recommendations for treatment of initial C. diff infection. We will separately look at recurrent C. diff infection, but now let's take a look at the very first episode of C. diff infection. We should break this into non-severe, severe, and fulminant episodes of C. diff infection, and the definition of non-severe includes a white blood cell count of less than 15,000 and serum creatinine less than 1.5. And for these non-severe patients with C. diff infection, the new 2021 IDSA guideline actually recommends fidaxomicin as preferred regimen over vancomycin. This recommendation is made because it has been proven that fidaxomicin has lower rate of recurrence of C. diff infection, and although fidaxomicin, a full treatment course, costs about almost $5,000, cost effectiveness analysis probably favors the use of fidaxomicin over vancomycin in patients with an initial episode of C. diff infection due to its greater effectiveness with respect to sustained clinical response, but implementing this recommendation probably reduces equity due to variation in medical insurance coverage. Now, in settings where access to vancomycin or fidaxomicin is limited, IDSA suggests using metronidazole for an initial episode of non-severe C. diff infection only. And this is because of inferior efficacy of metronidazole for this infection. Now, it is important to avoid repeated or prolonged courses of metronidazole due to risk of cumulative and potentially irreversible neurotoxicity. Now, because of cost of fidaxomicin, it is likely that for the foreseeable future, vancomycin will continue to be used for most patients. However, as cost starts to go down and as people start to adapt this new recommendation, we will see increased use of fidaxomicin for patients, which will ultimately reduce the risk of recurrent C. diff infection. Severe C. diff infection is defined as white blood cell greater than or equal to 15,000 or a serum creatinine greater than 1.5. For these patients, metronidazole is not an option because of inferior efficacy and high risk of complications and mortality in these patients. So again, fidaxomicin is the preferred regimen according to the 2021 guideline, and vancomycin is also an option as an alternative to fidaxomicin. And we also have fulminant C. diff defined as either hypotension or shock, or ileus, or megacolon. And ileus is basically, if there's obstruction in the colon. And for these patients, it is recommended to use a higher dose of vancomycin at 500 milligram, either PO, or if the patient is unable to take oral medications because they're either in hypotension, shock, or because of clinical instability, it can be administered through a nasogastric tube. And in addition, it should also be coupled with IV metronidazole, and this is because if there is an obstruction in the GI tract and this oral vancomycin cannot get to the site, which is basically into colon, this IV metronidazole will basically surpass that obstruction in the GI tract and will be able to infuse from the blood into the GI tract and get to the site of infection. And this combination has actually been shown in observational studies to reduce mortality, and that's why it's recommended here. And for ileus specifically, since oral vancomycin will not get to the site of infection, you may consider adding rectal instillation of vancomycin, basically at the same dose of 500 milligram 4 times a day. And it is important to note that for fulminant C. diff infection, fidaxomicin is not recommended because it has not been studied for these patients. So all the studies of fidaxomicin excluded patients with fulminant C. diff infection. Now you will see that one thing that's clear here for non-severe and severe C. diff infection is that fidaxomicin has a clear advantage of twice daily dosing, so it's BID, whereas vancomycin is dosed 4 times a day, so it will actually improve adherence. Now, one thing to note is that while these are treatment of C. diff infection, it is important to target the underlying cause. So it is important to discontinue therapy with the citing antibiotic agents as soon as possible, as this may influence the risk of C. diff infection recurrence. So, if a patient is on fluoroquinolones, for example, it is important to, if possible, to discontinue as soon as possible. Now, one thing that may be controversial is the use of anti-motility agents, since these patients have diarrhea. And because, C. diff is toxigenic, and, some people argue that because we want the toxins to get out of the colon, it might be a good idea to not use anti-motility. IDSA guidelines actually say that addition of anti-motility agents such as loperamide as an adjunct to specific antibacterial therapy for C. diff infection may be safe, but they do acknowledge that there are no randomized controlled trials conducted to evaluate the safety of that. Okay, now let's take a look at recurrent C. diff infection. So for the very first recurrence, so this is someone who already had C. diff infection one time and got treated, and then had recurrence 2 to 8 weeks after treatment. Again, fidaxomicin is the preferred regimen. And for these patients, also another preferred regimen is an extended pulsed dosing version of fidaxomicin. You basically give the same total number of doses. So, if the normal dose is 200 milligram twice a day for 10 days, that's a 20 dose regimen. One study looked at giving the 200 milligram PO/BID for 5 days, and then every other day dosing for 20 days, which you end up with the total number of dose overall. And this actually reduced the number of recurrence to the maximum. And of course, if cost is an issue, alternative regimens include prolonged taper and pulsed vancomycin. And what that means is that you basically give 125 milligram of vancomycin 4 times a day for 10 to 14 days. And then you basically taper it down to twice a day for 1 week. And then you taper it down to once a day for 1 week. And then you taper it down even further to every 2 to 3 days for 2 to 8 weeks. So this is why it's prolonged. And this has been shown to be effective for recurrent C. diff infection, although it has not been compared head to head with fidaxomicin, so it's not clear if this would be more effective than fidaxomicin. So for that reason, it is alternative. And lastly, of course, especially if someone who initially received metronidazole and then they had recurrence, vancomycin, the usual dose of 125 milligram 4 times a day for 10 days is an alternative. And metronidazole is not recommended for any recurrent C. diff infection. Now let's take a look at recommendations for second or subsequent recurrences. And basically fidaxomicin again is the preferred recommendation, as well as the extended pulsed fidaxomicin dosing. An alternative recommendation is prolonged taper and pulse vancomycin. And of course, the regular vancomycin dose followed with a chaser. So the chaser is that you do the regular 10 days of vancomycin and then you do rifaximin 400 milligrams 3 times a day for 20 days. And then at this point, because you are at the second and third and fourth and fifth recurrences, and this becomes really burdensome, some of the effective treatments that are reserved for this phase includes fecal microbiota transplantation. So this is recommended for after 3 C. diff infections episodes. There is also adjunctive bezlotoxumab, 10 milligram per kilo, just one time. And this basically, because of the long half-life of 18 to 19 days, it will basically stay in the body for about 3 months. So it's very effective in reducing recurrence of C. diff, and that it's important to note that bezlotaxumab is really to reduce recurrence. It is not for the treatment of C. diff infection, so that's why it's adjunctive. So for example, if you give it with vancomycin, the vancomycin will be for treatment, and bezlotaxumab would be to reduce the risk of recurrences. And it's important also to note that bezlotaxumab data is in combination with vancomycin or metronidazole. There are limited data with giving bezlotaxumab along combined with fidaxomicin. Now, in settings where logistics is not an issue, patients with a primary C. diff infection episode and other risk factors for C. diff infection recurrence may particularly benefit from receiving bezlotaxumab because of its effectiveness in reducing recurrence, especially people with risk factors such as recurrent C. diff infection episode within the last 6 months, or age 65 years or older, immunocompromised patients, and severe C. diff infection on presentations. Now, one thing that's important to note is that in patients with a history of congestive heart failure, bezlotaxumab should be reserved for use when the benefit outweighs the risk. Lastly, there are some recommendations for prevention of C. diff infection. The IDSA guidelines say that there are insufficient data to recommend screening for asymptomatic carriage and placing asymptomatic carriers on contact precautions. They also say that it's important to minimize the frequency and duration of high-risk antibiotic therapy and the number of antibiotic agents prescribed to reduce C. diff risk, and also to restrict fluoroquinolones, clindamycin, and cephalosporins, because these are very high risk for C. diff infection, except for surgical antibiotic prophylaxis. So those should not be restricted. And often you will see that antimicrobial stewardship programs do restrict the use of fluoroquinolones. For example, it is a bit more difficult to restrict cephalosporins and clindamycin because of their clinical utility. And the 2017 IDSA guidelines regarding probiotics, they mentioned that there are insufficient data to recommend probiotics for primary prevention of C. diff infection. So they need to see more clinical trials. And the more recent 2021 American College of Gastroenterology guidelines recommend against probiotics for prevention of C. diff infections in patients who are treated with antibiotics. They also recommend against probiotics for prevention of C. diff infection recurrence. This concludes this presentation.